Well, folks, it's 7:59, and this is David Rawson, founder and president of the Canadian Academy of Clinical Sleep Disorders Disciplines. Welcome to our bi-weekly Wednesday webinar series, which started last September. We're happy to produce session number 6 tonight. We have Dr. Jerry Hugh, a general dentist with all sorts of experience in chronic pain and sleep, and he's going to speak to us tonight on the systematic review of all bite techniques for mandibular repositioning devices customized in dental sleep medicine. Dr. Jerry Hugh is from Alaska. He and I are also on the board of directors of the parent group called the AACD. And so we've been working hard to upgrade the programs there, and our academy, we hopefully will be able to tap into that as well. Finally, you need to know, you may not all been reading all of your emails, but Bianca's been working very hard to create a library of these talks. They are all recorded in 2 sessions, the presentation followed by the question and answer session. So you have 2 videos per webinar. They're about an hour and then 45 minutes or so. They're available on YouTube. They're now also available on our website. So if you go to our website, across the top, there's a webinar banners. It'll take you directly to the list of them, and you can watch directly from there. Is that correct, Bianca?
Yes.
Okay, so you don't even know how to make YouTube work if you don't want to or can't do that. So that being said, it's a pleasure to bring to all the way from Alaska. You folks need to know that Dr. Jerry's just digested his lunch. It's around 4 o'clock in Alaska, and we are later in the evening here. So we've spanned the continent already with our speakers from all over the globe to bring people to you. So without further ado, Dr. Jerry Hugh is going to speak on the systemic review of all bite techniques for MRD customized sleep appliances. Dr. Hugh, welcome to Canada.
Well, thank you so much, David. And I'm very, very happy to be doing this for the Canadian CACSDD. There are a couple of things I just want to get out in the very beginning. So if some of you would like a list of references, some of the slides are new, so I'll put that together and that will be available later. As well as the slides, just briefly mentioned, this will be recorded. I'm okay with that, absolutely. But if you want to use any slides or whatnot, please ask for permission. I really appreciate that. So I'm just going to get going because I feel there's going to be a lot of questions. So I kind of want to give some preliminary disclaimers. So when I look at dental sleep medicine, I break up really all the treatment modalities other than surgery, of course, to a static view versus a dynamic view. So when you think of orthotropics and things with ortho, it's more dynamic. Also, with just the MRD world itself, even though it's a static appliance holding a position, I also believe that the bites can be categorized just as well as static or dynamic. And when we get into that, you'll see what I mean. So very, very happy to be here. And again, please do ask questions. We're going to have time for that. You know, over the years, I really, really have found, and although there's no randomized control study or a major meta-analysis to show this, but I do believe that every person has a sweet spot. Every person who comes in, they're 3-dimensional and they're very unique, and their bite position and everything is to him or herself. And that goes for geriatrics to teenagers that we're doing the MRD appliances for. So, you know, MRD is a customized oral appliance therapy. There's so many brands and so many materials. And this is really not only to talk about the bites, but also what's important when we do an MRD. We have to look at the biogunk. We have to look at all the different things that are part of long-term success. And when we go through the slides, you'll be able to see each of them as I break them down as to their purpose. But once again, we're looking at a static position that you find with a bite, whether you use this type of bite or that type of bite. We are looking to have therapeutic value and long-term success with the mandibular reposition device. So I kind of wanted to say, every time when I give this lecture in front of an audience, I always ask first, I said, you know, who in the United States or in Canada is allowed to make a diagnosis for sleep apnea? And of course, the audience members would say it needs to be a board certified sleep MD. And so we established that, okay? Now, of course, the standing order or the prescription for the appliance can be made by a nurse practitioner all the way to a primary care physician, ENT, etc. So when I say that we must first start and think about what is important then to drive any of this forward. And I think we all know the answer to that. We have to have the blessing of a board certified sleep MD. So their opinion of us, their opinion of how we treat, how successful we are, the side effects, all of that really, really matters. And when I talk to MDs, not just board certified sleep MDs, any MD or DO, what drives their conversation always is studies and literatures and research, right? So oftentimes when you go to even a lunch and learn, they're not going to give you any attention unless you come up with citations and references and things like that. So I want to say, though, to be on a very, very fair basis, we're looking at a lot of studies in the past that, yes, are randomized controlled for CPAP. However, I want to point out that a lot of it is on the efficacy, but not on the effectiveness. So when we look at long-term mean disease alleviation, the apnea load or the apnea burden, technically with oral appliance therapy or other modalities in dental sleep medicine, we really, really got a good advantage with that. But our weaknesses is we don't have many meta-analysis or above in this chart. So keep that in mind. But this also says it's very important for us as dentists to never forget that because the driving force is the medical doctors for this, they're the ones that we have to have the blessing. We must have more studies. We must get together as a dental collective, if you will, and produce those studies because that's what's going to drive. We have to think about this one thing in our hearts. There's over 1 billion with a B people in the world who are underdiagnosed, undertreated with sleep apnea. And now so many literature of comorbidities, whether you're talking about the beta amyloid proteins with Alzheimer's dementia, to cardiovascular stroke risk, the whole 9 yards, which I'm sure you're all aware of. So once again, I am going to probably talk about some basics all the way to advanced because I don't know the audience, but it's important that the people understand from even the basic standpoint where I'm getting at. Okay, thank you. So this is very, very interesting because when someone is, especially severe sleep apnea who has to try CPAP first, if they fail the CPAP, what are they left with, right? Sure, there's surgeries, and that's a whole separate subject. And there's, of course, debate on that. But their actually last hope is oral appliance therapy or a dental modality. So it really, really makes me think deeply that if you are a patient who is potentially going to die from untreated sleep apnea or have all these comorbidities that make you highly dependent upon big pharma and medications, right? So if I were, for example, to say that you are a non-responder to oral appliance therapy, that means that you have become really the last hope, and that failed. It's really, really sad. I mean, I've seen, when you say that to a patient and they really want something to improve their life, their quality of life, and you can't do it with oral appliance therapy, it's just sort of like what are they going to do? So I say it's very, very important that when we say to a patient that they're a non-responder, we're going to respect their 3D anatomy and we're going to respect that they come in with their own unique sweet spot therapeutic position, okay? And I really, really firmly believe that. This is also why instrumentation, equipment, and really, taking continuing education classes is so vital because we really, really need, and our Hippocratic oath, which is, I think, the next slide, is related to this, right? We have an oath as healthcare providers to really try to help the world and to do no harm. And so that means that if someone comes in and they had a car accident and they have a cranial strain, they have a side bend, their face is not symmetrical, for example, and you're looking at a sweet spot, well, sometimes if they're deviated way to the right or to the left, you may want to look at lateral dimension. You may want to look at all these other dimensions because there may be a position that's not only better, but also more comfortable, less protruded, for example. So we'll kind of get into that. So those are very important things to keep in mind. And so this 3D idea, I really think is the future. We have cone beams, we have everything now technological wise, if you will, that really allows us to measure and to put the proof in the pudding that these positions are 3D and not one-dimensional. So we have to consider certain things I kind of just mentioned, for example, on a car accident, or if a person just grew up, and there's a lot of pediatric literature out there that shows that your whole craniofacial development, so much as to even the position of breastfeeding to your diet and how if you're a mouth breather versus nasal breathing, all of that will contribute to who you are presented to the dentist for treatment, right? So we have to look at those things, look at the asymmetries. In my office, we have a symmetrograph, we take photos, we look at things. And then if I'm gonna make a static mandibular repositioning appliance, I'm going to consider those things. Of course, I have equipment and things to measure. We'll get into that as we get into different bites, but these are very, very important for you to consider. So I think there's, of course, the literature has more dimensions, but if we just look at the XYZ and think about an airplane flying through the sky, the plane can move with a pitch, it can move, roll in the sky, it can have a yaw. And I think if you really consider your mandible when you're eating and chewing, there is at least these 6 dimensions that we have to consider, in addition to how the body has been compensating and any asymmetries or any things that you can detect for the patient's presentation. So other anatomical conditions, of course, we all know that size of tongue, macroglossia. Every time I always use this, the patients really get it. If they have underdeveloped arch, I say that your tongue is like a semi 18-wheeler truck and it needs to be parked in a small garage. So that's why you would see all the, scalloping and the thrusting issues and things like that. There's just no room for it. We look at the buccal vestibular mucosa. We look at, Malampati is one dimension, but there's also a vertical dimension. So Malampati, you get the horizontal grade. Samsu Young, you get the kind of the curtains, the vertical grade. So look at those things. If you have pharyngeal closure, that's going to be important. We have to see if the patient's presenting already with a TMJ, TMD issue, because if we make a mandibular repositioning device, and you are going to require an excessive amount or a high amount of protrusion, you have to keep in mind TMJ and TMD issues. And what we really, really don't want in situations like that is, okay, thank you, Mr. Board or Mrs. Board Certified CPMD for referring me to the dentist. And when the dentist made my appliance, I wore it for a couple of weeks and oh my God, it is like, oh, it's so sore and like ache and I have a headache. And, so what's that patient going to do? That patient's going to go back to the board certified CPMD and complain. And then the board certified CPMD is going to have in the back of his or her brain, maybe I should think twice about referring to a dentist. So keep that in mind, right? Also think about nasal patency. We know we need to be obligate nasal breathers. We need to have nitric oxide the best we can to fight inflammation, to fight endothelial dysfunction, the whole 9 yards. So that's very important. Sleep position, of course, you guys know that there's positional sleep apnea. There's also sleep hygiene. Those things are also very much correlated. And it is tied to when we do an oral appliance therapy or we do anything dental sleep medicine, all these things are all connected to each other. So please keep that in mind. Of course, the muscle constrictors and the collapsibility, they all go together. And you can see sometimes you'll find that, you don't have proper exercises, whether it be myofunctional therapy, things that you need to do adjunctively. You'll get the vagal plexus and other pathways upset. And you can see the vagal nerve, very, very important. All those pharyngeal constrictor muscles are innervated by them. So keep these things in mind. And I think when we do an appliance, it's not just really a slap a bite in and here you go. It's all these factors, these asymmetries and these presentations that are very, very unique to each individual. So again, this is just to back up more of my philosophy is if you do a dental implant, even if you did a guided surgical thing, you have to do all the the ICAT and the anatomage type of assessment in order to put the implant in the most ideal position with the proper bone density, etc. So why is dental sleep medicine or therapeutic bite position any different? So again, like I can't re-emphasize or underscore enough that a 3D assessment is really needed for the best, most comfortable long-term success, not just efficacy, but really effectiveness of the oral appliance therapy. We're one body, we're connected. And I think we all know that if I, for example, have a longer leg than the other leg and I don't wear a corrective shoe or an orthotic, one side is always going to compensate more than the other side. And so that's very, very important to keep in mind that when we make an oral appliance, it's to be used every night. And so we want to make sure we look at all those factors. So we'll review the size of tongue first, and these are things that maybe just to review. Again, we talked about macroglossia. These are red flags and things that you do as a dental sleep dentist, medicine dentist, if you will, that you would talk about. And I really like to go over this with the patients because, if they see things and they, a lot of people are visual, and you can really tell them that, hey, there's an arch issue. Of course, if they said, well, I don't want to be tied to an MRD for the rest of my life, I don't want to have a wheelchair, then of course you can talk about orthotropics. I'm not going to get into much detail with that, but of course, there are cases that I've treated and the many of the gurus, quote unquote, treated that are successful. But again, when you look at evidence-based, they're mostly case series and feasibility studies. I know some of these big gurus are going to try to trend white papers and things like that, whether it's Stanford or Harvard or whatnot, but they're trying to get major research published for that. And so, but to stay on topic, we're going to continue on these red flags that we look for that are also important. So buccal-vestibular soft tissue, the palate mallepoly, so young earlier I said it's not just the horizontal, but the vertical, if you will, and let the patient see that. Of course, there are other things that when you have an oral appliance in place, you got to think about. So again, if we have TMJ problems or prior TMD pain, if some people have the eagle syndrome, when they swallow, they feel there's a poke, well, maybe the size of the appliance. You can get super bulky appliances to very, very minimalistic appliances. And I'm not going to say pros or cons for any appliances whatsoever. This is a neutral organization. We're not, just for one company or anything like that, but do consider those things. Think about all these other factors, and they're going to be important to the patient as they report back to their doctor or their board certified sleep MDs during a follow-up. So one equipment I have in my office, of course, is the Echovision pharyngometer rhinometer. And for those of you who aren't familiar, it uses sonar. So it's like bats flying through a cave, or when dolphins, the sonar stuff. And it gives you a cross-section. This is not 3D rendering, but it gives you a cross-sectional analysis so that you can see if there needs to be a turbinate reduction, if there needs to be septal spurs that are removed, or any type of issues with the deviated septum, septoplasty. Those things, again, are very important because keep in mind, even though we're doing MRD for OSA, we are also trying to encourage what's healthy, and we know that obligate nasal breathing is very important. So the rhinometer would be used, and if I find these issues, and especially if you look at the sinus cone beam and you see that they need to go to the ENT, it really does help us create connections. The local ENTs, both in Anchorage and in my hometown, know that I look at this stuff, and there's kind of a cross back and forth referral. So that's very, very important to think about that. And, the one thing is you don't, I recommend you have an Echovision. I recommend you have a cone beam. Because it's really, difficult to really ascertain sometimes or write a referral. But, if not, at least get some myofunctional therapy going. There's exercise and things that they can do. I know Audrey Yoon at Stanford, and there's Height. She's a hygienist. She has myofunctional therapy exercises, and it's going to help in the long run. So we got to think beyond just teeth and appliance. Very important to keep in mind. Of course, sleep position. is very important, especially when you look at the home sleep test results. You see positional apnea. Think about something like a slumber bump pillow or a Medcline pillow. You can Google those, or you can have patients directly buy from the websites. Having perhaps a more 30 to 40 degree upright angle. I know some gurus, I won't name names, but they recommend that, of course, people sleep in a very, very dark room that's cool, and to sleep naked, because if you go back to how Aboriginals or Aborigines or the native tribes and how they were, everything as close to nature as possible. Of course, obviously, if you're in a very, very heated environment and stuff, that's going to create things with sleep issues and stuff. So again, we are earlier talking about these things about presentations with asymmetries and side bends and cranial strains. There are specialists that are out there, chiropractors. You guys could be aware. There's AO, Atlas Orthogonist. There's SOT, Sacrooccipital Thoracics. There is also Rocobato, physical therapists, and they can help with these asymmetries and things. It's actually really critical if you're doing orthotropics to have these interdisciplinary people help out. But even with MRD and looking for therapeutic bite position, it's very, very important and to not skip. So I always tell my patients, this is the pharyngometer, so it's also part of the Echovision system. And when I use it, I always talk about a balloon. So when the balloon is filled with air, it's round and nice circular, but once you expel all the air out, then it kind of collapses into this weird collapsed status. So I think of the airway, the same thing. I think of the Starling's resistor, the peak rate, the flow. When you have that, everything is patent, but then when you blow the air out, you will see collapsibility. And so what I do in my office when I'm looking at different bite techniques and bite positions is I use the Mueller's collapse. In the Mueller's collapse, it's modified because I have the patients sit upwards. And the reason why I do that is because if they are reclining, there is sort of a defense mechanism. We all know that when we try to do the distal lingual occlusal of number 18 or 31, and in Canada, the second molars, I don't know the Palmer notation, but anyways, anyhow, you have to fight the tongue, you have to do all these things to really fight against the patient's natural ability of wanting to stay patent. And so we have the patient sitting up and we perform a modified Mueller's collapse. And then we can look at technically any bite philosopher, any bite positions, and really see how that is. Dr. Atul Malhotra did studies and found that certain numbers, centimeter squares, correlate to how the risks are, like 35 times more for all comorbidities, and to how to mitigate that by looking at different positions and things like that. So the collapsibility, of course, is very important. And I always, when I use this, I always think of the weakest link in the chain is how strong everything is. So I look at the minimist or the minimal spot, and I treat from that finding to see if I can increase that. Okay. So this again goes along the lines, but I sometimes patients will say, well, Dr. Hu, why are you taking all this time to measure? Well, you can think of it when I went to Hong Kong and I wanted a tailor suit. I mean, I've never been like, wow, they took pins and it feels like every little inch they measured my body, but that suit is the most comfortable, so customized suit I've ever had. Same thing with shoes. I use the example, my wife loves shoes and she likes to go to Nordstrom's, and I can't imagine if the shoe salesman says, we just have size 10, and if your feet are too small, I just want you to kind of limp along until you get used to it, and if they're too big, please enjoy the calluses and please enjoy all, and then eventually you'll break them in or they may rip. No one's going to go to that shoe salesman. And so again, there shouldn't be any difference for us when we look at finding the bite and finding the sweet spot, if you will, for the patient. And so in 2019, AADSM gave some guidelines on what they think oral appliances are. And they've actually, some companies did a survey and ask board certified CPMDs, what they think about oral appliances and what they need to be, especially alluding to this paper. And so what they found from the studies was that if you do have an effective position, that they need to be maintained. We know that in airway, 1 millimeter can make a huge difference, right? So if we have an oral appliance that later starts, having slop or having different movements, or it becomes, cracked on one side or whatnot. Those things are important because, again, we're treating a long-term issue, right? We want to make sure that the materials that we use will be maintaining that. Especially if we do a lot of homework and we find a therapeutic position that we think, wow, really is great. And then we use a sleep test or a polysomnogram to find out its efficacy and say, wow, it's great. And then 3 years later, the whole position is not maintained. Remembering 1 millimeter of difference can make a huge outcome difference down the road, right? And if that ends up being not as effective, then you can see a whole slew of things, the vagal plexus and all those other things that we talk about will be kind of affected with that lack of maintenance. And so this is kind of alluding to that one survey that they did. And it's really sad. I want to say that in 2018, I think that there was 2.1 million CPAP intolerant documented cases, right, in the United States, if you will. But there were only 200,000 oral appliances made. So something is really, really wrong with the picture. Now, I understand that, of course, the diagnosis part really is from a board certified sleep MD. I get it, and they have sort of kind of the control over it all. But what we do, I can't underscore it anymore. What we do at MRD, we have to think about the long-term outcome. And again, don't forget the Hippocratic Oath. We're supposed to do our best to really try to make that patient's life better. And, as dentists, I thought I was just going to be a tooth doctor, but how sweet it is that we have the ability right now to really not just, save lives, but improve quality of life and all these awesome things that you can see with dental sleep medicine. So again, having a 3D respect to me is very, very important, and we have to not forget that the board certified CPMD, they have the control in North America on how cases get treated. Okay, so 200,000 oral appliances made when we know, right, 2.1 million are CPAP intolerant. So why aren't they, coming in our doors left and right? So these things, please keep in mind. So getting to specifics about the type of oral appliances, we'll get to the bites soon. And the precision is very, very important. So, when you think about milled appliances, we have the technology now to be very, very precise. Again, think about the 1 millimeter difference, right? Can make a big, big impact on airway. So when we're taking, impressions, or they're being, handmade and this and that, which I'll get to the next slide. I don't know if you guys know, but a lot of the oral appliances are actually handmade. And I'm not going to name names, but so many of the dorsal fin types, you could go on and on. A lot of them are handmade. They're not precision milled. Of course, there are more than one company that mills their appliances. So, but keep that in mind, because when you have handmade, there is human errors. I had one patient that really, really loved his appliance. He wore it. It was efficacious. It was wonderful. And then about a year later, the dog got to it. Even though I warned him, I said, dogs love oral appliances. And we had to make actually 4 different appliances from that same company to try to attain that same outcome. So when there is, variability doing handmade appliances versus something that you store like in CAD/CAM and there's a data file and things like that, and it's precision milled, it's something really to consider. And again, this, of course, it applies to Canadians as well as Alaskans. Sometimes we get 20, 30 below weather here in Soldotna and in Anchorage. And so if I took a polyvinyl siloxane impression and the FedEx guy's out there, right, with the truck, and the back end of the truck is not heated, so it could go literally from 12, 13, 15 below to California or to wherever my lab is to make my oral appliance. And you can see, of course, there could be distortions and things like that. So that's very important to keep in mind. So again, really, we're at the technology age where we can really become fine-tuned to get a precise thing. So again, there's the slap issue that occurs, the handling of things, slippage with those herped arms and things like that, that'll happen. And again, if we found a sweet spot and we did our homework to find that, then we must really try to respect that these are things that can down the road create issues and then more negativity, if you will, to the certified MD. Of course, this also on the size, bulkiness, and comfort has to do with long-term success in that the size of the tongue. Some appliances could be lingualist to respect tongue space. It's all related to comfort, which to me also is related to compliance. So these are things I think that are very, very important, again, to consider. Biogunk, if we tell our hygienist to say, hey, look, you need to come in for your periodontal maintenance because when you're swallowing all these bacteria, Streptococcus sanguis and things like that, you're going to increase your cardiovascular risk for stroke, etc. Well, then if we have an appliance that is so filled with nastiness, you can smell that appliance just looking at it, even though we're on digital, but I can look at that and I can kind of remember how some of them smell, right? So it's kind of like, ew. So if they're putting that in and out all the time, don't you think that if we're going to practice what we preach, we need to have the appliance be as clean as possible? So if you have a very, very dense appliance made from controlled cure PMMA, or versus things that are super porous like nylon. I've seen some nylon appliances actually turn brown, some little black. And so when you look at it, it's kind of like, ew, right? So that's something important to keep in mind. Again, of course, there's tooth movement and side effects. The University of Pacific, with one company, did find they use the Rose paper and the Little's Index in the orthodontic literature to look at how much tooth movement is when you use rigid appliances versus the other types. So the other types would be something like a flex appliance, flex material, excuse me, things that are not as rigid and sturdy. And they found that technically the more sturdy ones really truly act like a true orthodontic retainer. And so, if you have braces as an adult or ortho treated, you have to wear a retainer for the rest of your life. So sometimes when you use the material of choice to be rigid, it actually serves as a retainer, if you will, which is something good to consider. So now we get into the various bite techniques. And so we always, most people, and I don't want to say anything good or bad, but I kind of have to present it a little bit into the way it is. So most people use the George gauge. Of course, it's the most cost effective. The forks are very, very inexpensive. But again, we've already are kind of talking about the importance of 3D, and we're only looking at AP. And I would really even debate, I've talked to many, many TMJ, TMD gurus, whether they're neuromuscular or CR, whatever, they all believe that vertical is much more forgiving than AP. So when you're looking at George gauge, you're looking only at one dimension, 70% protrusion, or 65 or whatever, but you're looking at narrower goalposts, because if you get, TMD or muscle strain or hypertonicity of muscles from that, again, we're going to create a problem with the patient going back complaining. So again, this is one-dimensional. It's fast. The positive side, I suppose, if there's any, is the cost factor and the time in the chair. But I really, I call all dentists to really think about the patient and not just do a one-dimensional analysis. With a matrix system, of course, it's just a more fancier George gauge. And the thing that I love the idea that while the former matrix was during a polysomnogram, of course, they came with the Matrix Plus that you can use with a home sleep test. And that's nice. But again, first of all, we're only looking at one dimension of the bite. But I've seen some, especially literature, the controlled, randomized controlled studies, they'll show a patient that they have to be at 90 to 100% protrusion in order for them to be a quote unquote responder. And I just can't believe, this is kind of like that first slide I talked about. I can't believe if I told a patient that they are a non-responder and I only looked at one dimension and not looked at others and jutted their jaw forward 100%. Of course, that's going to lead to a lot of potential TMJ, TMD issues, right? Then we're getting a little bit more into the dynamic realm. So if you look at the George Gates, the Matrix, those are again are pretty much static bites. There's not much, involvement. So when you look at the Moses bite, there's a kinesiology aspect to it. They have these shims, and you can look at how there's response, but this is a dynamic. And so we're looking at least into not just one dimension, but how the body responds to different vertical and things like that. So it's a very, very good. Of course, there's the Moses appliance as well, but the Moses bite does take care to kinesiology. The swallow bite, of course, it's pretty fast, but again, you're looking at movement. This is again not that expensive, but a lot of people say there could be a lot of variations, subjectivity, and things like that. So, but the swallow bite, some people still use, and to me, it's still, in my humble opinion, a little bit more than just here you go, 70% George Gage bite, and then we're going to make an appliance from that. Of course, the phonetic S bite, you have even several camps, but they're all really awesome. There's Steve Olmos, and there's phonetic S bite, the sibilant, I can't ever say that word, phoneme registration. And, you count numbers, and I know there's a lot of experts out there that, I mean, almost every time they get awesome post home sleep test results, and the position is usually comfortable. And again, this is dynamic because we're looking at that bite. And I'm going to say something when I get to the pharyngometer bite, though. Remember that all these bites, you still can use instrumentation before the oral appliance, before the definitive oral appliance is made, to validate or test and see, to give you more idea. I think that when we do a lot of guesswork in the beginning, and we rely upon the calibration or the titration of the appliance, it kind of sends also a bad message, because first of all, especially in Alaska, they're going to have to make multiple trips, and people live quite far away from my clinic. And so if they have to drive 40, 50 miles or more kilometers just to get to my office, you can see how that can be a problem, right? So make sure that you consider those things to do before the oral appliance is made, because you always look better, and wow, you hit the sweet spot and it works, and we don't need calibration. It's much better that way. The neuromuscular bite is very, very interesting. It's very dynamic. So you use the K7 and ultra low frequency TENS. This is not the TENS machine that you use on your abs. This is ultra low frequency, so the waves are longer. It creates an antidromic effect, so you cannot reach action potential on your muscles. So it's really getting rid of all that lactic acid, pre-ingrammed unhappy muscle type of thing. And then once you have the position, the patient, not the position, the patient tensed and relaxed. Sometimes they also add the Newcom and other equipment to really relax. Then you capture a bite. There's different camps out there that, there is the tag bite, this bite, but it all falls under neuromuscular bite. What I really love about neuromuscular bite, though, for airway and for dental sleep medicine, is that this looks into a position that is extremely comfortable. I've actually kind of did an own little one patient study, one case study, where I did a pharyngometer bite, several bites. And in terms of the most comfortable position, because I have the muscle EMGs, they're all tied up. I find that the neuromuscular bite really is generally the most comfortable. But in terms of being efficacious, I have to go to a pharyngometer bite. But I'm sorry, apnea guard is, I think the pharyngometer bite comes later. I'm sorry, so I thought it was next. But anyways, the apnea guard does look at vertical, and it does look at AP. So this is developed by a good friend, Todd Morgan. So that's something to consider. But again, this is looking beyond one dimension. So that has a lot of favor for me. And then there's the Andra gauge. The Andra gauge has the lateral. So remember those patients that have side bends or asymmetries, deviated septum. The Andra gauge is very, very fantastic, and I really use that as well. The apnea mat fit, that's a really cool way of looking at it. It's not the doctor seeing from Vivos, but a different doctor seeing in New York. He's an oral surgeon, I think, as well. He developed artificial intelligence and algorithms where you supply a CT scan, and it has questions on how you measure and how you put these different landmarks and stuff, and it spits out an XYZ coordinate for you to take a bite. And then when you do that, then you send it to the lab. But it really is a really cool thing. And as you use their system, it's artificial, it's AI, so it'll learn from it more and more. It becomes more and more accurate. But again, these are really cool, dynamic, multi-dimension analysis, which I think is very important. So here's the pharyngometer one. I use the pharyngometer just to verify everything and anything. So, and you can do that. I mean, if you're a George gauge user and you have EchoVision, you can see really if I put someone at 70%, you only have 4 choices, if you will, for the George gauge, but you can look at different positions. There's areometrics jigs. You can have the patients by on the jigs. You can shift left and right, or you can actually do a little bit of pitch and roll. You can do things like that, if you will, to capture your bite. I like to use the pharyngometer bite because, again, when I do the modified Mueller's collapse, it allows me to assess and ascertain how effective is it at making the minimum cross-section of the airway, if you will. Remember, the EchoVision pharyngometer actually records from your incisor area to your velopharynx, to your hypopharynx, to your glottis aperture. So it really goes up, 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 and that sonar gives you a mapping, if you will. And then if you're able to, again, get all the air out and perform a proper Mueller's collapse, of course, comparing apples to apples, having the patient sit in the exact same position with a good posture, and then be able to compare where the bite position takes that reading of the collapsibility of the airway, if you will. It's very, very awesome, because when you know that, or if you have instrumentation like the EMGs on the K7 with the ultra low frequency TENS machine, you can see that the muscles are happy and the patients are comfortable. You really are doing a lot of homework knowing that that position is going to be well accepted and have long-term success for your oral appliance. So what I did, because I felt really passionate about, even though most of the dentists have George gauge experience, and sadly, it's still most people use that. I wanted just to bring one extra dimension, the vertical dimension, and this has been published in the peer review journal. I'm a one single dentist guy up in Alaska. We're not super populated, so it was a case series study. It was a feasibility study. It was 30 patients in a row that was going to my dental sleep practice side. And 26 completed studies. The others moved out, other things happened, so we didn't include them. But what I was able to conclude was that when I respect vertical, when I look at vertical dimension, just adding one dimension more than a George gauge, I'm able to not have the patient protrude on average 5 millimeters less, which is very significant, but also I did not do any calibration or any titration once the oral appliance is made. So it was really cool because, again, it's not randomized controlled or meta-analysis. I can't even afford that, there's no way. But anyways, I'm able to show that all these 26 patients did not need any titrations, did not need whatsoever. So I put the homework because, again, I'm adding one more dimension and adding more analysis versus just the George gauge one-dimensional view. I'm also, I know Dave knows I got some, I have a patent. I started a startup company in Melbourne, Australia, but soon down the road, we're going to have alpha beta testers and stuff, but Who Verifier would be very important because I would love to have patients, dentists with their patients verify all 6 dimensions and have that assessed prior to making the definitive oral appliance therapy. So that is sort of on its way. So again, this is towards the end of my slide presentation because I don't want to neglect the fact that, remember, I talked about if you're CPAP intolerant and you're looking for the dentist and they do oral appliance therapy and they really truly are a non-responder, you looked at different dimensions, you look at that, or they just don't want to rely on an oral appliance for the rest of their life. And I know it's controversial because, you know, the orthodontist in their literature says that after your growth spurt or you become an adult, there's no way you can really change or grow bone or whatnot. But let's just say for PC, political correctness sakes, that there is no growth in bone. Let's just talk about bone remodeling in adults, right? When a patient, for example, comes to me and they're not responding to the mandibular appliance therapy and they already failed the CPAP, I'm sorry, like, you know what? Again, it's back to my Hippocratic Oath. I will tell the patient that this option isn't like your, you know, studied literature backed by millions of people thing, but there are so many cases, oh my goodness, and even so many experiences with patients myself, and this includes from pediatrics all the way to adults, that literally without any appliance in their mouth, when I do their post home sleep test, it's with nothing in their mouth, you will see a significant drop in RDI, AHI. You'll see oxygen desaturation levels improve. You'll see REM. You know, oftentimes when you look at REM, that's when worst things are the worst. But if you've actually expanded their palate and you've added myofunctional therapy and also interdisciplinary options, you've really, really given the patient a second chance. And then if they, on top of that, watch their diet and nutrition and the exercise, wow, the sky's the limit. I'm a prime example of that. I did go through some orthotropics. I've lost over 100 pounds. I've been a chubby kid all my life, overweight, and the last one to be picked in PE. I hated when they did teams and things like that. Every time when I, you know, tried to do exercise and things like that, it just really never worked. But back then, I didn't know anything about sleep or airway or, you know, leptin and ghrelin hormones. I was a stress eater, I had all those things. But, you know, it's really cool to be able to have your palate expanded. And I don't just mean like a Hyrex or a Ricanator or a transverse expansion. I think of a concentric expansion and having the mandible follow and those things as well. So those are really important things to consider because, you know, it's their life, it's their quality of life. It's, you know, when you're in your geriatric age, you want to be available to attend your daughter's or granddaughter's wedding or their whatever, right? So we want to make sure that we as dentists can provide through our Hippocratic Oath the best treatment possible. There's just some options for kids as well. I have a whole separate lecture if the Canadian ACSDD is interested in the pediatrics down the road that I can give. There's a lot of companies out there and they all really, really work well. And so thank you very much. I think I'm at about the 50-minute mark-ish. So David, do you have some questions for me?